Good afternoon, everyone. I'm Emily Akhtarzandi, Managing Director of AtlanticLIVE, and welcome to our discussion this afternoon, Combating a Crisis, our Atlantic Festival look at the opioid epidemic that is ravaging most of the country with no end in sight. The numbers are stark. According to the Centers for Disease Control and Prevention, on average, more than 110 Americans die every day from an opioid overdose. That puts drug overdoses as the #1 accidental killer of Americans. In 2016, more than 63,000 Americans died from an overdose, most of them from opioids. And on the front lines, the deaths are rising in part due to synthetic opioids, such as fentanyl, a highly potent drug that can be fatal in small doses. The number of deaths from fentanyl overdoses doubled in recent years. So today, we'll talk about what governments and the medical community can do to treat addicts, stop people from becoming addicted in the first place, and to stop the highly fatal and illegal fentanyl from reaching our streets. Before we begin, I'd like to thank the Association of American Medical Colleges for their support in making today's conversation possible. And a note of housekeeping before we begin: please silence your cell phones, but keep them out to follow the conversation online. We're on Twitter at AtlanticLIVE using the hashtag #TheAtlanticFest, all one word. And we want to hear from everyone in the room today, so we'll take questions after each session, and someone will walk around the room with microphones. And now to begin, we start with a conversation on treating pain and addiction responsibly and the medical community's role in curbing misuse. And so for that, please welcome Michael Botticelli, the Executive Director of the Graken Center for Addiction at Boston Medical Center and the former Director of the White House Office of National Drug Control Policy, and Dr. Chinazo Cunningham, a professor at the Albert Einstein College of Medicine. And joining them and here to lead the conversation, please welcome Atlantic staff writer Olga Kazan.
Hi, thank you. And thank you guys for being here. Well, we're here to talk about such a big problem, and what's a little bit frustrating about this one is that we have a cure for addiction. Medicated assisted treatment helps people recover, yet this is still such a huge issue around the country. So we're here to talk about what else we could be doing to improve this problem. So I want to start, Michael Botticelli, you ran drug policy under Obama. You know, there's this big opioid bill making its way through Congress. What do you make of the provisions in that bill? Are they enough? And if not, what else should the federal government be doing?
Sure. And it's the first time that I've been not a government official for a very long time, so I feel a sense of freedom in terms of talking about those kinds of things. One is, let's start from the macro level, and I think part of what we really tried to do is, particularly under the Obama administration, is really pivot this away from a law enforcement criminal justice issue to a health issue. So I think when you look at the totality of the bill itself, I think it really focuses quite squarely on a number of, kind of health-related provisions, and I think that there are a lot of kind of good provisions in the bill. I think, from my standpoint, and again, I can say this now because I'm not in government, while we've seen some investment of new money into this issue, I don't think we've seen it nearly to the extent and to the magnitude of the problem here. And I think there's folks that have drawn a lot of comparisons to, so we know that drug overdose deaths now surpass our peak of HIV deaths that we had here in the United States. But if you look at comparable funding levels, we haven't seen nearly that kind of response to be able to do that. I ran a state system for 9 years when we desperately knew that we were underfunded. And desperately knew that we could do more, but we really needed additional resources to be able to do it. So while I think that, again, there's lots of good provisions, and it's great to see Congress that is not known for taking action on this issue and doing it in a bipartisan way and largely focused on health-related responses, I still think there's more that we can do from a funding perspective.
Yeah. Did you have anything to add to that?
I would absolutely agree. I mean, I think that the analogy to HIV is a great analogy. We don't want to remake history here. We have a lot of lessons to learn, and we've done an amazing job with HIV and really managing that illness. And we can do the same thing with addiction, as you mentioned, we have treatment. And it's just the problem is that people who need the treatment are not getting it. And so we really have to revamp the healthcare system, and we have to incentivize healthcare systems and providers to actually provide the treatment that works.
And it's so interesting. I mean, you and I were talking backstage about how a provider, a doctor would never say, I don't want to treat someone with diabetes, but it's actually a problem in getting enough doctors, especially into the rural areas that are afflicted with a lot of addiction, to actually provide the medication-assisted treatment. Can you talk a little bit about why it's been so hard to build up this workforce and what else we could do?
Absolutely. So there's a tremendous amount of stigma around addiction. There's also stigma around addiction treatment, so medication for the treatment. And so doctors and other medical providers grow up in the same society that everybody else does, and the messages that we've been hearing for decades about addiction, about just say no, that it's a choice. And so it takes a huge amount of effort to change that. In addition, really so few providers are trained. So when I was in medical school, which was a long time ago, I had 1 hour in 4 years of training on addiction. And unfortunately, I don't think that much has changed in a lot of medical schools around the country. So we have a tremendous amount of work to do. And so I do think at a state or federal level, we really need to incentivize medical schools to train providers, residency programs to require this as a competency, and healthcare systems to ensure that there is treatment offered.
Yeah.
I would absolutely agree, and I have a crass way of saying it, and that's, for a very long time we've treated addiction as an optional healthcare activity, and we can't just look at it that way, despite the fact that it's probably the most prevalent disease condition that a primary care provider, certainly an emergency room doc, an OB/GYN is going to face. And so part of it, and I like to think, so in Massachusetts, all 4 of our medical schools got together, developed a core competency curriculum that all of our medical students have to take. We are looking as an institution, how do we make sure that every emergency room doc, every primary care provider, every OB/GYN actually has to go through the waiver training and be able to get some modicum of training. Because I think for us as an institution, part of what we have to say is that this is not, you can't just opt out of treating people with addiction, despite the fact that they're already there. It's not as if we're going to be attracting this whole new population of folks. These are people who are already in our care practices.
Right. And I think it's interesting because I think so often we think of addiction, oh, the person can show up to a rehab facility and they'll be taken care of there. But maybe you guys could talk a little bit about what some of the other kind of roles are out there for, let's say, employers or for hospital emergency rooms or even for the prison system. What else could those communities be stepping up and doing when it comes to treating addiction?
So I would start out with, just even thinking about the healthcare system. So we really need to create systems where any place that anybody touches the healthcare system, they can access treatment. And so right now, I'm a primary care provider, and we have developed a system in primary care, but that's not enough. And so we need emergency rooms, we need hospitals, we need mental health treatment at all of those places to be able to provide or at least facilitate access to treatment. I would also say about a big issue that I see, I'm in the Bronx in primary care, and a tremendous number of our patients who have addiction have histories of incarceration. And that, and people are at really high risk of overdose once they're released from jail and prison. And so most jails and prisons really don't do anything about addiction, don't offer any treatment. And that's an area that we really need to focus on and to change because the risk is really so high of overdose.
Right. I would just follow up on that. So, and these data hold true nationally. So in Massachusetts, people who are recently released from incarceration overdose and die at 120 times the rate of the general population, often in the first couple of weeks of release.
And that's because their tolerance has gone down, right?
Tolerance has gone down. To Dr. Cunningham's point, they are not getting good treatment, and particularly medication-assisted treatment behind the walls, and use that as a transition point. Rhode Island actually started in their Department of Corrections introducing all 3 FDA-approved medications, and they saw a significant decline in overdose mortality. So focusing on our criminal justice system, first of all, how do we divert people away from the criminal justice system in the first place? But if they're there, getting them good evidence-based treatment, and particularly medication-assisted treatment. And we're seeing pockets of this. Rikers has been doing this for a very long time. And transitioning people to the other side. The last thing I'll say is I think there is this kind of misperception that when you think about people, particularly with opioid use disorders, that this is largely a poor and a Medicaid population.
Yeah.
And actually, Kaiser Family Foundation showed that about equal percentage of those are commercially insured by employers. And I think that employers can really step forward in a much more meaningful way to think about what does their benefit design look like? Are they providing evidence-based services? Can we do things to change the culture and climate? Like, you know, as a person in recovery, and a lot of the data show that people who know they have a problem are afraid to ask for help because they're afraid what their employer is going to think. They're afraid of what it's going to do to their career trajectories. So I think we can engage the employer community in a much more meaningful way, and the impact that that can have as it relates to just the number of employees that they cover, I think can be significant.
Absolutely. And I think one fear that some people have been having, especially people who suffer from chronic pain, is like, well, you know, there's going to be this crackdown on opioids. I'm not going to be able to get prescription opioids anymore from my doctor because they're going to be worried about addiction. How do you, in the medical setting, balance that? You know, if someone comes in saying, I have chronic pain, I need medication that works really well, how have you changed up kind of what options you offer them or how you ensure that they don't?
Right, so that's a really great question, and it's a really huge challenge for many, many providers. I mean, we go into medicine to help people, and when people have pain, we want to help them. But we definitely now see, you know, the harms associated with opioid use. So, you know, I would start by saying certainly we want to provide non-pharmacologic treatments, so not medication, so treatments like physical therapy or, you know, acupuncture or exercise. Unfortunately, many insurance companies don't offer adequate coverage for a lot of these non-medical or non-medication treatments. And then when we go on to medications, we want to really provide anything before opioids, and so opioid-sparing strategies. And then, you know, if people still aren't getting the kind of pain relief, then going to opioids, but really reducing the number of pills, the dose of the pills, and the duration of the pills, because we know all of those are associated with an increased risk of addiction. And so what we do see now is that there's a lot less overdose deaths related to prescription opioids. The problem is there's unintended consequences because now deaths related to heroin and fentanyl have dramatically increased. So I think one really important part of this with pain is we have to think about the unintended consequences here. And we really need to study how to do this better. I mean, we really are lacking a lot of studies to help guide treatment.
I wanted to ask you guys about something kind of controversial that I've been writing about a lot, which is harm reduction approaches like safe injection facilities, fentanyl test strips, the kind of things that people can use if they're not quite ready to enter treatment, but they are kind of still using and want to use more safely. What's your view of those, or how could those be implemented?
So I definitely think that harm reduction should be one of the philosophical frameworks in which we work. I mean, our goal is to reduce harm, period. And you know, you can't treat somebody who's dead. So people are dying every single day in this country. So I think we have to think about every potential option. Everything is on the table until we really get this under control. And so, again, I think, you know, there's a huge spectrum of use or of addiction, and some people are willing to come into the healthcare systems and others aren't, and we should be providing services to everybody.
Yeah.
This is Rob glad I'm not a government official anymore. No, I think it's true. I think that we really do have to acknowledge that if you look at only a small percentage of people are actually getting treatment. And if you look at kind of the biggest share of people who have a substance use disorder, you know, a number of people are not ready to ask for help yet. And it does beg the question, like, what do we as a society offer them for those, like, yes, we want to motivate people to get care and treatment, but how do we as a society feel about protecting people from harm as it relates to their drug use? And are people with active drug use deserving of harm and care, of care? And I think for a long time, we've seen this as a moral issue, and we say, you know, if you're still using, we're not going to treat you, and we're not going to engage with you until you're ready to stop. And again, we don't do that with other diseases. We don't say to someone with diabetes, you have to have a perfect A1C score before we're ready to treat you. And I think what we do is engage people where they are and move them toward healthier behavior. And I think it's really important for us to do that. I think there has been, again, no data to support this. with any harm reduction approach, whether it's been access to sterile syringes, even naloxone distribution, that somehow that perpetuates or accelerates drug use. And there's no evidence that that is the case. So I think, particularly given the fentanyl and illicit issue, that we've got to really squarely think about places like safe injection facilities. You know, unfortunately, they're still illegal under federal law. I think we've seen the Department of Justice clearly signal that they are not going to allow for state or local experimentation with this. And I think that's really unfortunate because the data significantly support the fact that they reduce death, they reduce infectious disease, and they can create a glide path for people coming into treatment.
I'm going to take your questions in a second, so be thinking of your questions. But before we go to the audience questions, I want to ask about another controversial hot-button topic, which is medical marijuana, and how that can play a role, and along with other alternatives to opioids, in treating pain.
Yeah, so that's a great question. That's something I'm actively conducting research on right now. Oh. And so part of the issue about medical marijuana is we are really handcuffed in our ability to do research. So that's a really big problem at the federal level. We really need to be able to do research to figure out exactly what the benefits and harms are of medical marijuana. But the studies that do exist show at the sort of macro state level that there's a reduction in opioid prescriptions and also less opioid overdose deaths than would be expected. And this was published by our group at Montefiore and Albert Einstein College of Medicine. So clinically, I definitely see this in my patients. I have a lot of patients who use marijuana and say, this is the only thing that treats my pain. So I do think that having medical marijuana as an option potentially is less harmful and can be beneficial for patients with pain. People don't die of a marijuana overdose. People die of opioid overdoses. But we definitely need to be able to do a lot better research, and we need to change the regulations at the federal level in order to do that.
I will say, and I do think it's a fair statement to say that the federal government in many ways didn't incentivize that. I think that changed, and you're going to talk to Dr. Nora Volkoff, and I think we did a significant amount of work at the federal level to really look at, increasing the amount of marijuana that's grown for experimentation, of reducing some of the burdensome approval processes that happen in place, clearly signaling to the medical community that we wanted to accelerate research as it related to medical marijuana. And she can probably recite for you how many studies that we have going on here. But I also think that, as the non-clinician, that part of what I think that sometimes our politics can get ahead of our science here, and I really want to make sure that, if we are doing this, that we're doing this in an evidence-based way, that it is an approval, that it is an approved product, that it's done in a safe way to be able to do it. I'll leave it at that.
Okay, great. Well, I think we're going to open it up to the audience. There's mic runners coming around, and I see the first hand I saw was right there. The guy on the left, I guess, stage left. I don't know.
Thank you. Thanks for this panel, and thanks to you want me up? All right. My name's Rob Morrison. I work for the National Association of State Alcohol and Drug Abuse Directors. This question is for Mr. Botticelli. Full disclosure, a former member of our association.
Better be also, a softball. No, I'm kidding.
Well, also one of the most consequential leaders, I would say, in the addiction field in the nation's history, and we owe you a debt of gratitude. One question is the question about employers. A lot of employers, you picked up the fact that many people who need treatment are in employment settings, and a lot of employers have a role to play, but they don't know what to do. And I noted that your organization is working to help address this problem. Could you talk a bit about that and how to access those resources?
Sure. So when we established our center about a year ago, we made a commitment, our CEO made a commitment, that this is not just about how we provide better patient care. We have 6,000 employees at Boston Medical Center. Everyone has been touched by this, including our own employees and their families. And we made a commitment to not only deal with it from a patient standpoint, but deal with it from an employee standpoint. So we did a number of things. We sent out a survey to all of our employees asking them if they knew what their benefits were, if they were satisfied with their benefits. What was the culture and climate like? Because we know that stigma plays a big role, and one of the biggest issues was fear of confidentiality and fear of professional recrimination if they disclose and they step forward. Of things about how do you provide reentry pathways for people who are coming back to employment, for particularly those who have criminal histories. So employers, I think have a huge role to play here. And part of it is, and I'm sure we'll talk about this, the stigma around this issue is huge. And it particularly, I think, affects people who are employed, and they don't want to ask for help. They don't want to, sometimes they don't even want to access their benefits because they're afraid that it's going to be part of their medical record and someone's going to find out. So, I think that employers can really come to this work in a meaningful way. We talked about, not having access to evidence-based care. Well, they have a significant role to play in terms of not only what benefits they provide, but who are they contracting with? Are those providers providing access to the full continuum of care and services, including medication-assisted treatment? So I think if you think about, if we can get major employers to, and I think we are beginning to see this, of really thinking about this in a holistic way, that I think we can make some more significant progress.
See one hand and then, oh, okay.
Hi there, my name is Christian Archer. So you mentioned that there's not really much data around the harm reduction approach. And I was just kind of wondering, what information or data do you actually feel is missing or incomplete around opioid abuse in general that would be necessary to kind of help combat this crisis? Thank you.
So I would say, in fact, there's a lot of research around harm reduction that shows benefits. And so Michael mentioned, there's a decreased mortality, there's decreased risk of HIV and hepatitis C infection, there's improved linkage to treatment. So a lot of the, some of those data come from the United States, but a lot of it comes from other countries around the world. I mean, other countries have been doing this for a long time. And when the HIV epidemic came, because of their harm reduction approach, they had much lower rates of HIV than we do. So we really, I think, have a lot to learn from other countries who were a bit ahead of the curve on this compared to us. But I would say the data are there. I think the question is whether the will is there from a political standpoint.
This is where I think stigma comes into play, right? So stigma doesn't just manifest itself on the individual level. It manifests itself on the public policy level, right? And people have heard me say this before. Science and data don't drive public policy. People drive public policy. And as long as we continue to think of people who who have a substance use disorder as weak-willed and morally flawed, all of our public policy is going to reflect that. And that's why I think we've really got to think about, and it's part of the reason why I'm very public about my own recovery, that personal narrative changes people's minds and hearts in ways that science and data don't. Right? So think about LGBT issues. Like, part of the reason that the Supreme Court struck down the Defense of Marriage Act and made same-sex marriage legal in 50 states is that we know people who are openly gay. Right? So I don't think we can really underestimate the role that knowing someone plays. And there's data to support this. Right? Why are we debating climate change and immunization when all of the data support it? These are not data-driven decisions. These are public policy decisions that are made based on what we perceive people to be. And until we change that narrative, I don't think we're going to have public policy that aligns with the fact that this is a disease and that people who have this disease deserve care.
A woman in the center there. Is there a mic for her?
Thank you very much. You mentioned earlier the intersection between the criminal justice system and the drug crisis. I work at the Pew Charitable Trusts, and last week, Crime in the U.S. came out, and it showed an increase in arrests for drug abuse. And what is notable is that there was a 3.1% increase in arrests for men for drug abuse violations and a 7.7% increase for women. I'm wondering if you could talk about the gendered pathways to opioid addiction and whether there is a gendered approach to combating it. Thank you.
Yeah, that's an excellent question. It's not something that's really discussed that much. I mean, I think the issue around gender really comes up more around pregnant women and our approach to pregnant women. And our approach is often lacking in general for pregnant women. And I think it's more, again, about punitive issues rather than actual treatment. I just know in our system in the Bronx, really the vast majority of people who come in for treatment are male, 3/4 of patients. But I think that again, stigma probably plays a significant role in what somebody who's a drug user should look like. Certainly race plays a big role, and this is something that's near and dear to me. I'm in the Bronx. Most of my patients are people of color, and again, the response has been punitive as compared to actually, seeing this as a healthcare issue and a medical issue for treatment. So I do think, in terms of gender and race, we really do need to think about what our approaches are and how stigma affects those approaches.
Yeah, there's this intersectionality to various stigma that we see borne out in some of the data that you're saying. And while I think that we saw a lot of state efforts moving toward more robust public health response, pregnant women we saw going in the opposite direction, where you had states like Tennessee and Alabama and Mississippi actually creating enhanced criminal penalties for pregnant women who had a substance use disorder. Like that was really going to attract pregnant women to come into care. So I think we do have to acknowledge that part of what drives this opioid epidemic is not just the overprescribing of prescription drugs, that there are these social issues that have been with us for a very long time. And until we get to some of those root cause issues, that we're just going to have we might ebb the flow or the tide of this epidemic, but we're going to have other drug crises because fundamentally we are not really getting to some of these root cause social issues that have been plaguing us for a very long time.
That's a great point, and I think we're going to have to end on it. Thank you guys so much for coming in. Thank you all for being here.
And thank you, Michael, Chinazo, and Olga. And next up, please welcome to the stage Nora Volkow, the director of the National Institute on Drug Abuse, and U.S. Surgeon General Jerome Adams. And leading the conversation, welcome journalist Kathleen Koch.
Good afternoon, everyone, and thank you, too, for joining us.
Absolutely.
They say that the opioid crisis, the epidemic, has become so pervasive that almost everyone knows someone who's overdosed. Can I see a show of hands in the room? Who knows someone who's overdosed personally? I wasn't among you until Monday, till one of my best friends lost her younger sister. And Jerome, I know that this is personal for you. In your latest report, Facing Addiction in America, the Surgeon General's Spotlight on Opioids, you start with the story of your own brother. Talk to us about how his situation has really steeled your determination to end this epidemic.
Well, I've dealt with this crisis professionally. I'm an anesthesiologist trained in acute and chronic pain management. Grew up in the era of pain as the fifth vital sign, was told these things aren't addictive as long as you're prescribing them for medical indications. And quite frankly, been the doctor who gave out 60 Vicodin because that's what they told us you did in order to treat the patient. I've also dealt with it as the Indiana State Health Commissioner. I was at the helm during the largest HIV outbreak related to injection drug use in the history of the US. But until recently, many folks didn't know that I've been dealing with this personally. My brother Philip is in state prison about 10 miles from where we are right now. It started off with unrecognized mental health issues, anxiety, depression that he self-medicated with tobacco, with alcohol, with marijuana, and eventually someone gave him a pill. And that started him down his pathway. He ended up stealing $200 to support his addiction and was given a 10-year prison sentence. And so I talk about his situation for a number of reasons. I don't talk about it to invoke pity from folks. I talk about it because the only way we're going to get through this is to normalize it. We were having a discussion in the back. I think if you want to boil the opioid epidemic down to two things, number one, it's stigma, And number two, it's ignorance. If we can get rid of stigma, and if we can educate everyone about what the science is behind responding to addiction and all the upstream causes, then we will be better for it and we'll be able to tackle anything else that comes our way.
You know, that's a great time to transition to Nora, because Nora, your work is really so essential when it comes to ending that stigma, because you have found proof that this is not a moral failing, this isn't a lack of strength or personal will. This is a chronic disease. Talk to us about the biological underpinnings and how addiction changes the brain.
Well, we know, and we've known actually that addiction is a disease of the brain for basically more than 2 decades. And we know that because now with brain imaging technologies, which is what I've done as a researcher, is you can look inside the human brain and compare how the brain of someone that's addicted to drugs differ from that of someone that has not. That's from the brain imaging perspective, but we also, from studies in laboratory animals, we can generate animal models where you can actually make an animal addicted to a drug. And in the process, we've come to recognize, first of all, not everybody becomes addicted. Second, animals, not all of them become addicted. And we know that there is a very strong genetic component that makes some individuals more vulnerable than others.
Can we detect that yet? I mean, is there a test, or will there be?
No. No, we don't have. We know from heritability studies that if you have a family member, you have much greater likelihood of becoming addicted. But we do not know precisely what are the genes. And someone that claims to do so is exaggerating our level of knowledge. One day we will. At this point, we come to recognize what gene modifications may be playing a role. But the third important component that we need to address and think about it as addiction as a disease of the brain. Addiction is a disease of the brain that occurs in certain setups. Just like diabetes or obesity or hypertension require certain environmental circumstances for the individual to be exposed to these stimuli. So social factors are extraordinarily important in creating environments that are going to make someone that has that vulnerability more likely to end there, and others that can provide resilience. And this I highlight because this is an opportunity for us as a society to create prevention and create structures that will actually minimize the likelihood of people becoming addicted. And to the question about what happens in our brain, I've thought about it a lot and said, well, why can I can't show you, I am not allowed to show slides, but I can show you a brain. And any one of you, not being an imager, can see where the abnormality on the brain of a person that is addicted is located. It is quite categorical. I can show you the brain of someone that has a myocardial infarction, and you can also see where the infarct happened. Yet we have not been able, despite this clarity of information that's out there, to change the perception of people. So I think that what I try to do is, well, what does it mean that it's a disease of the brain? And what it means is that drugs, and this happens in people that have genetic vulnerability or are exposed to extreme social adverse conditions, the areas of our brain, the frontal cortex, that regulates our ability for self-control. So you may want something very much, and you can cognitively say, no, I'm not going to do this. Or you get angry at someone and say, no, I'm not going to punch them. And we all succeed on doing it. But that is because that area of our brain is functioning properly. I mean, it doesn't always function so well. If you're very tired, you're frustrated, you may lose it. But consistently, you have the ability of self-regulation. Drugs damage that capacity. And that gives you an explanation about why a person, even though they say to themselves, they promise to themselves, they are not going to take a drug, they are unable to stop it. And this was made, to me, I mean, how horrible it must be to make your brain, to say, I'm not going to do it and you cannot stop it. And I learned very late in life that my grandfather had killed himself. And he killed himself because he could not tolerate the fact that he could not control his alcohol drinking. And that is not a rare history. You see suicidality being the sad outcome on many instances. And as we're discussing the opioid crisis and the overdose fatalities, we don't realize that a non-negligible percentage of those may be suicidal behavior. And it's not just anymore about the concept of medically we need to treat it as an addiction. We need to change our narrative so that people don't start to develop this sense of total failure and self-hatred.
Jerome, I'd like to go to you now. Thank you, Nora. Clearly, when Nora says, so scientists, doctors have known for 20 years that this is a chronic disease, and clearly there's a lot of public education that hasn't been done. Now, the Trump administration has declared this a public health emergency. Tell us about this digital postcard that you have put out to try to rectify this lack of understanding.
Well, my job as Surgeon General is to communicate the science around health to the American people. And as Nora said, some scientists, some health professionals have known this for years. I'll tell you again, stigma and education. It changed my life even as a person who does this each and every day. The first time I heard Nora give a lecture and put up her slides of the brain imaging, it completely changed the way I even looked at it. So we've got a long way to go to educate even health professionals and providers. But 30 years ago, we had an HIV epidemic, and stigma and education or ignorance were killing people. C. Everett Koop sent out a pamphlet, Understanding AIDS, to everyone in America to help everyone understand how they could be part of the solution.
Sure. Remember when people thought if you hugged someone with AIDS, you could catch it?
Exactly.
It was terrible.
Exactly. Again, stigma and education. And so fast forward 30 years, we're in the midst of another epidemic. There is the equivalent of a 747 jet of people dying every single day from this terrible epidemic, like a 747 crashing every single day. And we need everyone across America to understand the steps that they can take to respond to the opioid epidemic. So I put out my own version of C. Everett Koop's pamphlet to America. We don't send out information by snail mail anymore. That's what my young people in my office told me. But we have a digital postcard on surgeongeneral.gov that details 5 steps that any one of you, every one of you can take to help respond to the epidemic. And I won't go through them, but I would encourage you to go to surgeongeneral.gov, look at that postcard, tweet it out, Facebook it out. You can print it out and take it and share it with other individuals if you're having convenings. But the high points are talk about it, number 1. Be safe with your opioids if you do have them, because 4 out of 5 heroin users got started with a prescription opioid. No addiction. Understand that it is a chronic disease and not a moral failing. Understand pain, as you heard the other speakers talk about. There are many alternatives to opioids, but you just have to ask. You've got to push a little bit, because the easy thing for us to do is to write a script for 30 Vicodin. Sometimes it's harder to get a little bit deeper and find out what those alternatives are. And then finally, be prepared. I put out the first Surgeon General's advisory in over 10 years, helping folks understand that they can save a life by carrying naloxone. Because of those people dying of an opioid overdose, that person dying every 11 minutes, over half are dying at home. They're dying in a bathroom, in a bedroom, in a garage. And so until we can invent an ambulance that can teleport to your house in 4 minutes, because that's how long it takes to have permanent injury from anoxia, we need every single one of you to be able to respond to an opioid overdose. The same as we expect in a room of this size, that if someone had a heart attack, we'd be able to have someone who knew CPR to respond promptly.
How are people responding to that call?
It's been tremendous. The call for naloxone prescribing is up 350% since our advisory in April. Retail dispensing is up 70%. So it shows that.
But what about the price? Is it still
price
problematic?
Price is still a concern. We've decreased the price of the injectable naloxone 70%. The price of the intranasal naloxone has come down almost to the cost of the generic. And we put out hundreds of millions, literally hundreds of millions of dollars in federal funding to states and localities so that they can purchase naloxone. So I'm not going to sit up here and tell you that it's still not an expensive product and that there aren't still barriers, but I will tell you that we are working with everyone to try to make it as available as possible, because you can't save a person if they're dead, again, as you heard in the earlier panel.
Nora, interestingly, referring to the earlier panel, the physician on the panel talked about her lack of training when it came to treating and recognizing abuse. You wrote a wonderful op-ed, I think it was in Scientific American about a month ago, making that case in precisely how we need to better train and educate and equip physicians to diagnose and treat substance use disorder.
Yeah, no, and I think that this is one of the aspects that we have a low-hanging fruit in terms of interventions that we need to do to address the opioid crisis, better training of providers. And I highlighted part of the problem that enabled the crisis to occur was the fact that medical students or clinicians were not being trained on substance use disorders. They didn't know if their patients were becoming addicted to the pain medications that they were giving them. They couldn't recognize it. And if they did, they didn't know what to do. That's number one. But at the same time, there has also been inadequate training on how to properly treat pain conditions, screen them and training them. So we have a gap in the training and education on pain and on substance use disorders. And that is something that we could change in a relatively short period of time. If we are very aggressive, if we provide the educational material to physicians that are already trained while putting it at the curriculum that will enable the new generation to be fully prepared. This is fundamental for us to be able to address the crisis, to have the trained personnel. On the one hand, that will basically prevent them from prescribing inadequately opioids, and other one, to be able to intervene on the treatment of someone suffering from a substance use disorder.
And you believe in medication-assisted treatment. Talk about that.
The data is not, I don't like to say I believe it. I mean, the data shows it.
It works,
It has shown it. I mean, we don't need any more studies to show what a large effect medications have on the treatment of opioid use disorder. And we are extraordinarily lucky. I mean, when those of you that are not aficionados of pharmacology, I mean, we don't have many medications for treating other addictions. We have alcohol, nicotine, and opioids. And in opioids, we have medications that actually improve your likelihood of surviving threefold when you are on medication versus when you are not.
What are you talking about? What drugs?
We have methadone, we have buprenorphine, and we have naltrexone. These are three different classes. And so one of our priorities as an institute at the NIH has been to develop alternative medications, expand, because they were discussing the issue of HIV, how effective we were. Well, how many antiretrovirals we've generated in a very short period of time.
But that took a huge injection of funds, right? Federal funds?
Huge injection of funds in order, and pharmaceutical industry.
Right.
So my perspective is we need to incentivize pharmaceutical industry. And how do we incentivize them? Well, right now, for example, insurances will make a big deal to cover, say, $1,000 per treatment a month, even though you don't do that for other type of medications.
You don't do that for diabetes, you don't do that for heart disease.
It is the stigma of addiction.
Interesting.
So, yes, it is a medical disease. By the way, well, we will consider paying it. The parity law asks us to do that. But you know what? We are not going to be paying so much money for this medication. So there is that element. So we're trying to actually expand alternative medications, where also, very importantly, the medications work. But we also have to recognize, so if you're not medicated for and you have opioid addiction, opioid use disorder, your likelihood of relapsing within 2 weeks is 95, 98%. That high, it's that high. And your likelihood of dying from opioids is very, very high. So, but if you are on treatment at 6 months, you still have a chance of 50% relapse.
So that medicated treatment has to continue
it has
for
to
a
continue,
lengthy period.
But the challenge is, how can we sustain patients to keep their medication so that they don't relapse? Mm-hmm. So we are trying to develop two things. One of them, medications that will make it easier for patients to be compliant. Extended release formulations, once a month as opposed to once a day. But also models of care that will make it easier for patients to sustain their treatment. So those are two aspects.
And then, Jerome, don't we also have to work with the doctors to overcome their resistance to prescribe the methadone, the buprenorphine?
You absolutely do, and the other speakers talked about this, but it matters to each and every one of you all in the audience, too. Let's look at my brother. He got a 10-year prison sentence for stealing $200 to support his addiction. Now, if you break down the cost, it's about $100 to $200 a day to incarcerate someone. Times 365 days a year, times 10 years, means that by the end of his sentence, you all will have paid between $500,000 and $1 million to have incarcerated my brother. He's going to come out. He's not getting treatment right now. He's going to come out, and as Nora mentioned, if he doesn't die from an overdose, he's going to have a significantly higher chance of relapse and recidivism if he's not provided any sort of treatment, the gold standard being medication-assisted treatment. So would you rather spend $500,000 to $1 million for my brother and every single person like him, or would you rather spend a couple hundred, a couple $1,000s to be able to provide him the evidence-based standard of care so that he can become a productive member of society? Don't do it because it tugs on your heartstrings. Do it because it makes financial sense. And every single one of you all is affected by every single person out there who is not getting the gold standard of treatment and is being pushed out there with a 95 to 98% chance of failure at your expense.
No, I'd like to go to you to talk about the, well, actually not, the issue of safe injection sites. What do you think about whether those are effective or not?
There haven't been many safe injection sites. I visited the one in Vancouver, which is actually very unique because it's in the middle of the city where it's a very, very high rate at one point of cocaine injection, now predominantly heroin and fentanyl injection. And I went to visit it because this site has shown significant improvement on outcomes. So they've decreased the mortality, that they increased the number of individuals that end up on treatment for their opioid use disorder. And they also
mortality is reduced by 35%, I think. It's huge.
It's quite significant. So that's what I was very intrigued. And they also, the other thing that was fascinating is they were able to, those that were HIV infected, to put them into treatment, and they were able to show that by treating them aggressively, both for their HIV and for their opioid use disorder, they were able to show a decrease in the incidence of HIV in Vancouver. So I wanted to see it with my own eyes, not that I have any other eyes, but my own eyes. And it was, the data speaks for itself. Again, it's not what I believe or don't believe. I mean, I'm a scientist and I guide myself by objective information. What I say, though, is that we need to actually understand that interventions can work in one context and then necessarily may not be the same in another place.
I want to go to Jerome really quickly to respond because we'll be going to the audience shortly for questions. What are your thoughts on, again, they do call these safe injection sites, but are they?
Well, I would say very plainly that we have to be very cautious about the words we use, and there is no such thing as a safe injection site. Because with fentanyl and carfentanil out there, you could overdose in front of me right now with carfentanil on board, and I could have 10 doses of naloxone, and I might not be able to resuscitate you. They're supervised injection facilities, but they are not safe injection sites. They may be safer injection sites, but they're not safe injection sites. That's number one. Number two, I don't take credit for a lot, and this is not something that I take credit for. It just is what it is. But there's probably no better expert on this in the country than me, because I was at the helm when we took Indiana from a state that did not allow for syringe service programs to one that allowed for syringe service programs in a very conservative rural community to respond to that HIV epidemic. And what Nora was getting into, and she and I have been on panels before, and we both agree about this, that in some these things are very context specific. You have to implement public policy with the public. And if the public doesn't accept it, if I'd set up a syringe service program without the buy-in from the community, the local sheriffs would have just posted up outside of the syringe service program and arrested everyone who was coming in or coming out, and no one would have gotten clean syringes. You have to implement it in concert with the community. And I'll finish really quickly with a quick example. I got asked this question in Philadelphia just a few weeks ago where they're having that debate. And I will tell you very practically from a public policy point of view, they've got one syringe service program in all of Philadelphia. And they drive a van around once a week and hand out clean syringes. I would much rather use my time and my energy right now in this country scaling up syringe service programs, which are more widely acceptable, again, because of the success that we've had in Scott County, Indiana, and in other places, than to lose folks fighting over a supervised injection facility, because I think I can help more people by scaling up syringe service programs than I can fighting for something that the Department of Justice has said is a violation of the Controlled Substances Act. So that's my opinion. I would rather focus on something that does work and that the federal government is funding and that folks care about than something where the data still is being developed in terms of applying that in the United States, and where, quite frankly, a lot of communities just aren't ready for it and are going to fight you on it.
All right, let's go to questions. And if you would, raise your hand and identify yourself. Where are the mics? Mics are in the back. Okay, this young woman here with the glasses.
Hi, my name is Margaret. I'm a graduate student at American University and a health policy fellow. With regards to funding policies, could you both touch on how Medicare and Medicaid reimbursements could help?
Excellent question.
I'll jump right into it very quickly. Number one, I will say that in order to expand treatment, we need to pay for treatment. And we've put out an unprecedented amount of funding in this current administration, but as Michael Botticelli said earlier, we still need more. So we need to look at all means to fund and expand treatment. As far as Medicaid as a source, in Indiana, we were able to expand coverage to folks through our Healthy Indiana plan, a consumer-driven alternative to Medicaid expansion. And this is very important because I think people fight over the vehicle, and then they lose, again, the bigger discussion about coverage. No one will argue with you if you say, we need more treatment and we need to pay for that treatment. People will argue for you if you start off the discussion by saying, I want it to be this way. So Medicaid expansion is something that is very politically volatile. As Surgeon General, I say we need to cover folks so that we can expand treatment, and we need to give states the flexibility to be able to do it in a way that fits in with their political beliefs and their culture.
You know, briefly on that point of paying, any thoughts on the congressional opioid measure that just passed the Senate yesterday? Now it's going to the president's desk. Is that going to give us the funding we need?
It's much more money than we've ever had before. We still need more. I'm heartened by the fact that it passed 98-1. Nothing happens in a bipartisan way in this town right now.
Pretty incredible.
And so it shows you that this opioid epidemic is a tragedy, but it's also a tremendous opportunity to bring folks together around something that is affecting all of us. And if we can really come together around the opioid epidemic and get upstream, as Michael Botticelli said earlier, then maybe we can turn this tragedy into something that 10 years later we're looking back and saying that was the time when we turned the tide, both on our ability to speak to each other and our ability to recognize that community wellness is important in so many different ways.
I'm going to interject on that because I also think in addition to, of course, we want to expand the ability for reimbursement of treatment, we have to also remove the barriers. And right now for Medicaid, there are barriers. So some of the states will not pay for coverage until you've actually shown that you failed other treatment, even though the evidence shows that medication is the gold standard of treatment. There are other ones that determine, well, we're going to pay for 2 years. There's absolutely no data out there that 2 years is sufficient. And actually, the data shows that the best outcomes are when you can provide sustained treatment for long periods of time. I think that that's very important. And the third item that I want to say is that it's not just about reimbursement. I think that we need to demand quality of care.
Yes.
And so that Medicaid can cover, but actually showing that the outcomes of that particular therapeutic intervention are the correct ones. Because in the rest of medicine, it's not that you can do whatever you want and you're going to get reimbursed. We need to demand quality of care and metrics that allow us to see how the different programs' outcomes are coming along. And Medicaid and Medicare could play an important role to facilitate this from happening.
And I know we've got to close. I would say go to surgeongeneral.gov because our new spotlight on opioids, you can read it cover to cover in 45 minutes. Can you spare 45 minutes to help us solve this crisis? We talk about what evidence-based treatment looks like because a lot of folks can't discern the good from the bad. Read our spotlight on opioids. Help us download and distribute our postcard to individuals. Play your role in responding to the opioid epidemic. One more really cool thing to check out, it's don'tliveinDenial.org. If you have a chance to go there, it's a great new ad. I was just in New York literally earlier today and last night for Advertising Week, and it's a great campaign they have talking about the denial that exists in communities, the stigma that exists, and again, how you all can be a part of overcoming it. So thank you so much.
Thank you both for joining us, and thank you all for, we're out of time for questions, but thank you for your interest in doing all you can to fight this epidemic. You know, last year the number was, what, 72,000 people, more than 72,000 died of overdoses. That's what, it's like 8 an hour? So in the time we've been up here, at least with 3 people would have died.
Exactly.
Very sad.
If a 747 jet dropped out of the sky every day of the year, you can make darn sure we would be doing a whole lot more about it than what we're doing right now, and that everyone in America would be worried about it and trying to figure out how they could stop it.
Amen. All right. Jerome, Norma, thank you so much. Thank you all for your questions.
Thank you, everyone. And next, for a session produced by our underwriter, I'd like to welcome Atul Grover, Executive Vice President of the Association of American Medical Colleges, to the stage. So welcome.
Thank you. Thank you. I appreciate the opportunity to be here today. And A lot of the things that I wanted to touch on have actually been brought up today. Medical education, stigma, the crisis that we're facing in stark terms of a jetliner crashing every day. I don't know that I have anything new to present to that, but I want to give you a slightly different perspective as somebody who's been a product of this system in medicine, medical education over the last 25 years or so. I appreciate my colleagues from Montefiore, Einstein, and Boston Medical Center talking about the work that they're doing. Hopefully I can highlight some of that as well for you today. I was sitting in the Atlantic session the other day, and thank you again for allowing us to participate, but listening to Secretary Clinton, and it reminded me of being a medical student here in DC in 1993 talking about healthcare reform, with a conversation led by then First Lady Clinton and Leader Dole. Nowhere in that conversation did substance use come up, nothing about addiction, nothing about pain management. In 1990, there was a paper published by Mitchell Max from the American Pain Society, where in the Annals of Internal Medicine, he said, it turns out that the use of opioid analgesics rarely results in addiction. This is where the science was for us in 1990. So as a medical student coming through, and then as a resident in 1995 in San Francisco, a lot of my exposure to substance abuse was really in the county healthcare system, in the emergency room. And I'll tell you that where we educate people, medical school is critically important. We're giving everybody the foundation of what it takes to actually understand addiction, how to get rid of that stigma, how to actually take care of patients and their needs and treat their pain and their psychic pain. But what sticks with you is when you're a resident and when you're actually responsible for taking care of patients right there in front of you at the bedside. And I remember being in San Francisco General's ER, now the Zuckerberg-Chan emergency room, and taking care of patients who came in, young people who had overdosed on opioids, on heroin. And at that time, our job was to give them Narcan, ensure they were breathing, save their lives, and send them out the door. And I contrast that with what else I saw in 1995. So this was San Francisco in the middle of the AIDS epidemic. And as a first-year resident, I was out in hospices seeing young men, mostly young men, filling those hospice beds. By the time I finished my residency in 1998, those beds were empty, not because those young men had died, but because of antiretroviral treatment. They had left. It was a success story. It was what we needed to do. And it does have a lot of parallels in terms of what we need to do to address this crisis, because the opioid epidemic is really, with its acceleration, with its impact, striking like a bullet through the hearts of our communities right now. And the way we approached HIV/AIDS was a completely different approach. In 1999, though, by the time I had finished my residency, the California State Legislature had passed a law saying that to be accredited as a healthcare institution, you had to collect pain as your fifth vital sign. In 2001, the Joint Commission said pain is the fifth vital sign. It was a smiley face or an unhappy face that had to be collected along with blood pressure, along with heart rate, oxygenation, and that, in fact, CMS or Medicare was going to pay us on the basis of how well we did that eventually. And so all of this is not to say that we should have known better, we should have acted more quickly, but that this is what the state of the evidence was. And part of my job today in working with teaching hospitals and medical schools, so we represent 141 MD granting institutions in this country, 17 in Canada, and about 400 teaching hospitals and health systems, several of whom you've heard from earlier today. And that may sound like a lot, but it's only 5% of the acute care institutions in this country. And yet we provide about 20% of all the care when it comes to addiction, substance abuse. 80-some% of our institutions actually have psychiatric inpatient beds and emergency psychiatric services. They're not present everywhere. So we see these patients every day. We see the most vulnerable, patients who are poor, sicker, who are suffering. And it's taken some time for our knowledge base to evolve, and it's still evolving. Part of the benefit of being in a teaching hospital or medical school is that that's where the research gets done. And I thank the NIH and NIDA and the federal government and yesterday's legislation and the appropriations bill this year, because we need to invest in that basic research. We need to figure out not just what the other medication managements are, but what are non-pharmacologic managements of pain. We're doing that at our institutions. We're doing it alongside treating these patients as they come in, and we're thinking more about prevention, about treatment, about stopping relapse. And in fact, I'll give you the example of Yale New Haven Hospital, where I'm a health services researcher by background, and all that basic science research, that basic building block of knowledge is important, with all due respect to pharma. That happens in America's teaching hospitals and medical schools. Half of that work is carried out by our faculty. But health services research is an important part of this as well. So in the emergency room at Yale, they figured out that, and I'll take you back to 1995 and my treatment with Narcan of a patient who had suffered an overdose, and that's all I did. That's all I did. I made sure that patient could get out. I prayed that he or she didn't come back on that shift. I didn't know what else to do. They've started using medication-assisted treatment in the ER at Yale New Haven. They found out it actually works. Well, who would have guessed? Just handing somebody a slip to say, go see a pain specialist, go see an addiction psychiatrist. Maybe you get an appointment, because guess what? There's barely any of them out there. And I was actually not happy to see that the Congress did not include provisions to train about 500 more doctors in pain medicine and addiction. But it's something we'll continue to work on. But it turns out those patients, if you intervene in the ER, are likely to stay in treatment longer and less likely to relapse. So we have changed that behavior. And this is what we need to keep doing, learning on the fly with the support of our partners in the federal government and others. But I want to tell you that I thought about the last session and thought a lot about Admiral Adams' work in Indiana and how we had to respond to the HIV epidemic and the speed with which they acted in the public health system. A credit to you and your team, a credit to Indiana University Health. And I have a son who's 16 years old. He has now lost somebody that he knows intentionally at their own hand because of their psychic pain. He's lost friends to unintentional overdoses because our kids are assessing risk in a way that they think is brilliant. No one wakes up in the morning. I have a friend who's a teacher, and he says to his class, nobody wakes up in the morning saying, I'm going to be a heroin addict today, right? But we haven't gotten there. What we're dealing with in terms of what's on the street now is incredible. And so I fear for my son every time he walks out the door. I fear for the other children in my neighborhood. And I think I saw a depiction of a JAMA article that was published about a year ago looking at our impact on mortality and life expectancy in this country through medical intervention. And part of the reason I work for who I do is because I truly believe in the advancements in biomedical research and what we're doing to move care forward, to move health forward for our populations. And with regard to the Atlantic, it was Axios presented this beautiful visualization looking at the impact on life expectancy of all these interventions. And I know that my colleagues at our institutions all over the country have brought down mortality rates from cancer, from heart disease, kidney disease, lung disease, you name it, you go down. They're all down here. But way up here, like a piercing by a bullet, is the decrease in life expectancy that's been driven by opioid use. And we haven't dealt with it yet. And unfortunately, this is all personal now. I think the last panel talked about that. But, this is not new. This has been around since I was a resident. And we're thinking about how to do this in an adaptive way, how to keep changing. It's not going to be easy. And I think what was brought up before about reimbursement, about insurers, about employers, about us as neighbors, not stigmatizing people in our community when they're suffering from a disease like any other, is critical. In May, my colleagues at the AAMC, my colleague Allison Whalen, who's head of medical education, is bringing together a symposium of educators for medical school residency, people who deal with continuing medical education for people in practice, working alongside the accreditors in continuing medical education, the ACGME, which deals with graduate medical education and residency, and we're going to try and bring people together at the national level here in DC in May, sponsored by the CDC. So this is a public-private partnership. It continues. We can do better. I look at the example of what we did in HIV/AIDS, the way that people have continued to respond throughout our communities. So let's get started. Thank you.
Thank you so much, Atul. And for our final conversation, a look at efforts to stop fentanyl from entering the country. And so please join me in welcoming the Acting Deputy Commissioner of U.S. Customs and Border Protection, Robert Perez, here with Atlantic Senior Editor Ross Anderson. Welcome to the stage.
Thank you. Good afternoon, folks.
Bob, this entire conversation is going to be about how difficult and hard and important your job is, so I appreciate you taking any time out to come talk with us today.
My pleasure.
I want to start to talk about fentanyl, and just I feel like the sort of ideas about how dangerous this drug really is have started to kind of penetrate popular culture, but I think it's always worth repeating. Is this the most dangerous drug that's ever been in circulation?
Well, thank you, Ross. 25 years later, as far as my career in law enforcement, I've never seen or encountered anything that is nearly as dangerous. So just to try to frame that out and put it in context for everyone, a typical, at least from what I understand, typical dose of heroin that would be lethal for an adult individual would be about 30 milligrams. Fentanyl, 3. And so it is unlike anything we've ever seen as far as the safety and the security is concerned for not just the folks who are unfortunately the victims and or the people who fall to being addicted to these substances, but for the men and women that are on the front line, working and trying to stop the flow, interdict what's coming into our communities, and really protect everyone from this terribly, terribly dangerous illicit trade.
Was there a sort of arc where, at some point you started to notice a trickle in of opioids that were synthetic, that were more dangerous than heroin, and then they kind of ticked their way up to fentanyl, or what, did we go from heroin to fentanyl just overnight?
So about 5 years ago, we in Customs and Border Protection seized a total of about 2 pounds of fentanyl nationwide. 2 pounds on what is usually annually, on average, narcotic interdictions for all of our agency in around 2 million pounds. So very, very small.
Yeah.
3 years later, that 2 pounds became 440. And just last year, we seized well over 1,000 pounds. This year, we'll seize just as much or a little more. So it has been a very, very steep spike or curve over the last 5 years of what it is we've encountered. Now that is, frankly, by virtue of, I believe, 2 primary things. Certainly, there's an ongoing demand issue, but there is unquestionably as well the profit-seeking motives of the transnational criminal organizations who are wanting to traffic in this illicit trade. But the good news, if there is some good news here, is that law enforcement, collectively, not just Customs and Border Protection, but the entirety of the law enforcement community, has gotten a lot smarter on how it is and what it is we bring to bear to interdict the drugs as they're being trafficked.
I want to talk a little bit about some of those new methods and tools that you guys are deploying to keep this stuff out of the country. But first, give me a sense of where is this being manufactured?
So 90% of all the fentanyl that we encounter is being made and trafficked out of China. The Chinese direct, if you will, fentanyl that comes to the United States, almost all of it comes through the mail streams or through express consignment packages. Now, there is a good portion that is also making its way into labs and or narcotics trafficking organizations in Mexico. And so that is the other, if you will, pathway and method most, supply chain method most significant that we encounter as far as the flow is concerned, emanating from China, going into Mexico either in finished form or raw chemicals or precursors, being made there and then coming through our southern border. In really traditional ways that we've encountered narcotics being smuggled for decades. On persons, in conveyances of all types, trucks and cars and the like.
Do we know, you mentioned earlier the profit motive, is that what drove the development of these increasingly potent, like why out of nowhere did this drug, was this drug developed?
Well, I think, at least from our experience, our perspective in law enforcement, unquestionably so. So the folks who are really fueling, if you will, what is being fomented here as far as illicit traffic are the same transnational criminal organizations and the drug trafficking organizations that are moving the vast majority, if not all of the world's and certainly this hemisphere's illicit narcotic trade. The same cartels that are primarily based out of Mexico that are moving illicit cocaine, illicit heroin, and the like, other synthetics like meth. These are the same organizations, really, with nothing but profit in mind, and certainly total disregard to the well-being and the health and safety of our communities, who are the ones behind the vast movement. Now, unquestionably, there is, look, the local user, the folks who are unfortunately, again, falling victim to becoming addicted to this stuff, who go online at times or in other ways and seek to procure these substances. But make no mistake about it, and that back end, the people involved in making sure that the stuff is getting manufactured and getting into the hands of these folks are pretty nasty criminal organizations that are out to do nothing but harm us.
If 90% of this is being manufactured in China, I wonder, has China been a real partner, for law enforcement organizations, whether it's you or it's DEA, are they coming beside you to help you stop this stuff?
Certainly on this matter, they have been, and we're encouraged by the collaboration we've had up until this point. So, along with Customs and Border Protection, as most folks might presume, the Drug Enforcement Administration, or the DEA, as well as Homeland Security investigations, we're all shoulder to shoulder. The U.S. Postal Inspection Service. We're all really immersed collaboratively on this effort, and a big part of what it is we're doing is working not just domestically but internationally to get at these illicit flows before they come. And so, yes, the Chinese have been receptive. They've been collaborative. In fact, we've had some operations targeted and emanating in China to try to interdict some of these substances before they even got overseas.
Were those pre-existing relationships that we had with whoever your Chinese counterpart is, or how did that work? How did that develop?
Yeah, it really pre-existing, Ross. So again, a big part of all of our portfolios is collaboration in general, and so as the drug trade or any other type of illicit trade, if you will, that these transnational criminal organizations, will lean toward, getting involved with and/or gravitate to. As all those emanate, we do lean on our counterpart agencies across the globe, and all the law enforcement relationships that we really established for, at times decades, to gain that collaboration. Now, again, with China, sometimes we've gotten some great collaboration in the past, sometimes not, but I'm glad to say that in this issue, on this challenge, so far we've had some modest success.
I know that you guys seized, you said something like 1,300 pounds, was it, of fentanyl last year, which is enough to kill every citizen in the United States. How much, if you seized that much, and I know this is speculation, but how much actually got through?
That's a great question. There is no real accurate answer. It would be a pure speculation on my part, or really on most people's part, to take a guess at that. But what I can tell you is this, is that the uptick in interdiction for me and for us really means, again, a couple things. First, that the demand continues to be a challenge. There is unquestionably a demand issue that, again, a lot of I think the previous speakers, delved into at length, that need be addressed and that is at the forefront of taking on this challenge. But it also speaks to what I believe, especially in the last year or two, how much smarter law enforcement has gotten and how much better we've gotten as far as the tools we bring to bear, the information that we're now gathering that helps us better manage this risk and interdict the flow. That's a huge part of why it is we're interdicting as much as we are interdicting. And so while unquestionably it's still making its way into our communities, last year alone, I will share with you, about 500 million international mail parcels entered the United States. Over 100 million express consignment parcels entered the United States. The growth by virtue of the explosion of e-commerce in both those venues have been in the upwards in the last 5 years, with express consignments more than 50%, and in the U.S. mail over 200%. So it's been an explosion of growth. So that sheer volume of what's coming in over our borders and internationally that we are going through certainly affords an opportunity for some of it to get through. But we're modestly confident that we're getting better every day to interdict more and more and stop, a big part of, or as much as we possibly can from getting into our communities.
How easy is this stuff to buy online? Like, is this something that you have to go deep, have the technical sophistication to get on the dark web for, or can you just do a Google search and an hour later you've made an order?
The dark web really is the primary and most used venue with respect to the internet, Ross. So that, again, is something that we have known for quite some time. It continues to be an ongoing and pretty complex challenge. But it speaks to the ease with which somebody sitting in their living room, somebody sitting home at the bedroom, again, who is unfortunately now fallen addicted to these substances, can literally go online, put in an order, and some days later have a parcel being shipped through the borders that we will have an opportunity to interdict, and that we're doing our best to try to get that information to interdict it before it ever goes any further than where it's originating from.
Let's talk a little bit about the tools that you have at your disposal that you mentioned earlier. I had read a news article recently that said that there was some risk in using canines for this problem because fentanyl is so inherently dangerous that even inhaling some small part of it could actually kill the dogs. You were just telling me, however, that you've got a large sort of team of dogs that is able to sniff this stuff out. Is that right?
We do. So last year, as we were continuing to explore different tools and technology that we can utilize to better, again, interdict what was coming through the borders, we typically will encounter at these mail facilities and express consignment facilities parcels or packages where the illicit drugs are actually enclosed in some sort of packaging. So the risk of direct exposure is relatively small. And so we began to pilot introducing fentanyl and the myriad of analogs, a couple dozen of which not only our forensics folks have identified, but the law enforcement community have identified, and trained our dogs to actually detect that odor as well. Fortunately, by the end of last summer, we were pretty successful with that. And now the entirety of our drug detection canine in CBP, more than 1,200 of our canine teams are all able to detect fentanyl. And so, again, we typically encounter it. Usually, again, smuggled and or sealed or packaged in a way that direct exposure is not common. Nevertheless, we've also deployed thousands of doses of naloxone, not only for countermeasures for accidental overdose with the canines, but also for our frontline men and women. That was something that, again, that since last year early on, we made sure that not only we afforded the opportunity to our men and women to have that at their disposal in case of an accidental overdose, but we complemented with very in-depth handling training and protective wear, instruction, so that people could understand how best to protect themselves as well if they have something in front of them that they believe might be containing some of these synthetic opioids.
Now, if you're talking about 1,200 dogs, and I actually don't know what the sort of, how many kind of points of mail flow there are coming into the United States, I imagine it's quite a few.
9.
What's that?
9.
Okay, 9. And so of those 9, are those dogs, like what percentage of the mail flow do you feel like they're scanning?
Okay, so great question. So we have 9 international mail facilities across the country, and about 25 or 26 express consignment facilities where our frontline men and women, our CBP officers, along with our canine teams, work out of every day. And so what we, by virtue of the volume that I just mentioned earlier, in addition to, while we're also balancing nearly 400 million international travelers coming in to the country every year, over 25 million cargo containers and trucks, and so on and so forth, what we absolutely have to lean on is our ability to manage that risk. And so that's where the advanced information and our targeting and analytic capability really comes to bear. So of those millions of packages that are coming through now, we're making great progress on the mail front with getting advanced information to be able to apply the same analytics and rules, if you will, to identify the packages that may present greatest risk. Those are the ones that we segregate, and those are the ones that get the more intense scrutiny, not only by the officers themselves, but by the canines and other tools that are at our disposal, like infrared spectrometers, that are handheld devices that allow the officers and our forensic scientists to detect the packages and without even opening them, see whether or not there's something in there that is of suspicion.
When you say the advanced knowledge, maybe you're not at liberty to share, but what are the sorts of characteristics? Is it like it's coming from a particular place in China? Is it the buyer maybe sort of located in a place that's fairly opioid intensive? What kind of things are you guys looking for?
Those two, all of the above, and then some. So it is a myriad of different types of information vis-a-vis the actual transaction of the parcels, the parties involved, their potential histories, but then also the entirety of the general intelligence that we are able to not only develop on our own, but that is shared with us collaboratively with our other law enforcement partners here in the U.S. that we mentioned earlier, and our international partners. CBP has a unique capability, and that is the platforms we have to synthesize all of the commercial data that's coming in associated, again, with these shipments alongside the law enforcement intelligence and make informed decisions as to how it is we're going to scrutinize what we scrutinize. And so everything you mentioned and then some is what is helping our men and women identify the greatest risks and hopefully get out in front of these illicit packages.
You just mentioned a little while ago that that your agency has identified something like 25 alternates to fentanyl, and I'm assuming that means other synthetic opioids like carfentanil or however you say it. The synthetic labs, how much of this is a technical arms race between agencies like yours and them? Like, is it the same basic chemical signature, for instance, for the dogs, or are you having to retrain them every time there's a new innovation, and how frequently are there new innovations in these things?
So that's a great question. I'm not a scientist, but I will opine to the best of my ability. So the analogs that we've identified, and CBP particularly has been a big part of doing that for the law enforcement community, from what I understand, don't necessarily provide all that much of a deviation by virtue of signature as far as odor for the dogs. But that is something that, again, our scientists are constantly looking at. And as the collective law enforcement community does identify more of these analogs, which, yes, the folks who are manufacturing these synthetics are looking to constantly alter some of the chemical makeup to frankly circumvent some of the laws that we have on the books, particularly our DEA friends, on how and what is scheduled. Now, they've already made some adjustments to that to enable law enforcement to better be able to interdict these synthetics across the board. But that was something and is something that is an ongoing challenge. And we do stay very current and on top of. And if and when we have something that we've discovered that we feel does warrant that type of retraining, we're perfectly positioned and very well positioned to be able to deal with that. Fortunately, up until now, we've been able to cover the full spectrum.
Talk to me about priorities a little bit. I know that you're tasked with sort of enforcing the laws on the books, no matter what they are, no matter what shifting attitudes might be. But obviously, we're in a moment culturally where marijuana is certainly less stigmatized and is seen as, it's just objectively less of a public health risk than something like fentanyl. How are you allocating resources differently to reflect both the rise of fentanyl, but also kind of like people mellowing on marijuana a bit?
Well, look, from a federal law enforcement perspective, anything and everything that is still considered illegal and or illicit is on the front line of all of our drug enforcement interdiction efforts. That is the charge that we have as a law enforcement agency and the charge and the mission that we carry out. Nevertheless, as we started out and we talked about the safety and or the risk associated with fentanyl, that in addition to this unquestionably serious national epidemic that we're facing, has certainly warranted us to redirect some of our resourcing into those areas that I just mentioned, those mail facilities, those express consignment facilities at greater levels that we had historically had them. So we've added some of our again CBP officers and men and women into those facilities, and also along the southwest border as well. As I mentioned, those are the two primary pathways where these drugs are coming into the country. And so without really compromising any of the drug interdiction mission in general, unquestionably, there is an absolute dedicated, heightened level of focus on all things synthetic opioids because of really what it has presented to our society by way of just this tragic death and risks to our communities.
The fact that this stuff is coming in through the mail, does that make it much more difficult to tap into the actual human, you referred to them as international criminal organizations or networks, however you want to characterize them. Is it hard to get to the actual people at the top?
It's a complex process, Ross. That's, again, a very good question. Very, very complex insofar that the first challenge is with international mail, we're only now beginning to scratch the surface of getting advanced electronic information. We've been able to get those types of data for years now in just about every other type of cargo stream of goods coming into the country. We're only beginning to get out on that in the international mail over the last couple of years. That coupled with, again, the complexity of going back along that supply chain and actually verifying the identities of the players involved, their locations, both here domestically and internationally, it definitely presents some unique challenges. But that's where, again, fortunately enough, Customs and Border Protection alongside the DEA, Homeland Security investigations, the U.S. Postal Inspection Service, and even all the way down to our state and local law enforcement folks.
Yeah.
You know, when they encounter and run into the things that they do in their local communities, we have task forces around the country where all that information is being shared, and it's being fed back into these really well established relationships from an investigative standpoint, where we can then go back and do our best to trace not only the origins, not only the supply chain, but get to the heart of the matter with these transnational criminal organizations and the individuals who are actually making this stuff and profiting from it, so that we can dismantle those networks as quickly as we possibly can.
One thing I wonder is how, given that in bringing these international criminal organizations to justice, international cooperation is so important. We talked a little bit about China. Let's talk about Mexico now. Are those relationships subject to political developments when you have a change in administration, different kind of rhetoric comes in about our neighbors on the southern border? Do you notice a fluctuation in sort of willingness to cooperate?
The political dynamic, you know, from one administration to the next, not unlike here, and you know, with our friends to the north in Canada and our friends to the south in Mexico, is certainly something that we all, you know, work through. Certainly, us career law enforcement officials work through. But I could tell you unquestionably the level of cooperation we have on law enforcement matters with both our partners, but particularly also since you asked about Mexico, is something that is unwavering. And so we're very confident, you know, despite and given, you know, the changes that we all go through, you know, with respect to administrations and folks that are actually running, you know, the countries themselves. These established relationships, these established partnerships, for the most part, are well intact. Again, they're decades worth of investments of collaborative, you know, information sharing, collaborative operations, and personal relationships that are quite lasting and very fruitful.
Do you have a sense, just in thinking about the business plan of these international organizations, how much more lucrative fentanyl has been for them? Like, is this, how would we compare it to something like Pablo Escobar's cartel in the 1980s? Like, how would those two, is the chief kind of fentanyl kingpin or queenpin, are they making just loads more money on this stuff than they used to? I'm not really able to draw an analogy with the 80s so far in the aggregate in that sense. But what I can share with you, if I'm not mistaken, so a kilogram of fentanyl in its uncut raw form, so wholesale. So the wholesale manufacturer selling it to the dealer who's going to get it, about $5,000 to $7,000. That kilogram of fentanyl could reap 10 times as much quantity and go for $80,000 per kilogram subsequent to that hitting the streets.
So I shared that with you because the profit is unquestionably there. It rivals absolutely any other type of illicit narcotic that's being trafficked at the moment. Heroin is nearly about the same as far as profit, generally speaking in its finished form. But as far as how it is and what it is, able to be spread, if you will, or cut, and then dispersed to the quantity and the expansive way that fentanyl is, not quite the same. In fact, a lot of the heroin that we're encountering now, at times, is also laced with fentanyl, which makes that particularly dangerous, again, and something that we're paying a lot of attention to.
Bob, like I said at the top, you have a very difficult job. Thanks for spending some time with us.
I appreciate it, Ross. Thank you.
And thank you everyone for joining us, Robert and Ross, and we hope you'll join us for later programming in here with a small business forum. And thank you again to AAMC for making this event possible. Have a good day.